The following program is a Town of Colonie television production of the William K. Sanford Town Library.
So, here's the first question. Is assisted death happening in New York State sub rosa? I don't know what that means, but you do.
Whatever it means, it is, I think, happening by doctors who are compassionate, by family members who are helping their loved ones who feel they can't go on living. But they're put at terrible risk when it does happen. Dr. Timothy Quill, one of the plaintiffs in our lawsuit, actually helped one of his patients to die in the late 80s, and then he wrote about it in the New England Journal of Medicine. After he wrote about it, the Monroe County District Attorney, which is where he was practicing medicine, sought an indictment for manslaughter under the statute which prohibits assisting a suicide. The grand jury, in fact, refused to indict Dr. Quill. And my guess is that they did so because they saw Dr. Quill as being a compassionate doctor doing what was right for his patient, practicing patient-centered medicine, which is, again, largely what this is all about, respecting a dying patient's wishes. Dr. Quill knew with that patient that he couldn't control her suffering in any way, and so he did what he thought was right on her behalf, and he really was very courageous in doing so because he could have been indicted and could have been convicted and could have been serving time in prison. He again is a plaintiff in our lawsuit, as he was in the first lawsuit, which actually went to the U.S. Supreme Court, which was decided on federal constitutional grounds, our case being sought seeking relief under state constitutional grounds or under an interpretation of the existing New York State statute.
Another point, if I may add, about Dr. Quill and Diane, his patient, was that he was her treating physician for years and years and years, and he knew her very well. And that's another point, I think, for this law, is that this relationship between physician and patient is what should be guiding this type of request. When it happens underground, you can have people who don't have this established relationship, and awful things may result.
Is there any problem with payment of life insurance benefits going to beneficiaries of the insured if the insured exercises aid in dying to end their life?
Go ahead, David. I'll chime in.
Well, the answer is no.
Right.
Life insurance policies are not prohibitive in this respect.
And it's built into the law in Oregon. It's part of the statute, and I think in Washington as well.
This is a little bit different tack here. I've heard several times not to call 911 because you lose your right to refuse treatment. Is that true? Michael?
Well, that's what happened to my mom. My mom was suffering from stomach cancer. We brought her back from the hospital. She was in her last few days. It was pretty clear that she would be dying soon. So we brought her back home. That day we brought her back home from the hospital. She really was having a lot of, she stopped breathing. My father found her in the room. She stopped breathing. So we called 911. They came. They said they were legally obliged to bring her back, do whatever they could to resuscitate her. Now the problem with Mom is there was no DNR order written. She did not have any written order. Even if she did, it has to be clear to the emergency crew that she has it. Otherwise, they're under a legal obligation to resuscitate her. My father and I did a block, did our old football tackling block. There's no way we're going to allow them to do this to Mom, knowing what she would not have wanted. And they decided to back off. Not because of me, because of my father, I think. He's bigger than I am.
What can be done for a person who has expressed his or her desire to have aid in dying, but is no longer mentally competent? For instance, somebody with Alzheimer's or dementia.
Unfortunately, unless I'm wrong, I don't think there's a provision for that here, but elsewhere in the Netherlands and in Belgium, you can have an advance directive for termination of life, as they call it there, with the aid of a physician, but not here, to my knowledge.
Did you say Belgium?
Yes.
Belgium. This one is to David. If after withdrawal of normal care and continuing only palliative care, a person may die in 10 to 14 days, why do we need to give him or her a pill to end their life sooner?
Because each of us should have the option as to how we're going to die, and for some people, palliative sedation, for example, may be sufficient, but many people don't want to wait 10 days or 2 weeks. They don't want to have this drawn-out process. They want to say goodbye to their family members, their loved ones, and then have a very quick and peaceful death, which is what happens when you take the medicines. Most people die within 5 minutes to a half hour. Why shouldn't people have this right if the other option is not sufficient for them? What difference does it make if they do have this right? If it's not a right that you would want to exercise yourself, then don't exercise it. But why prevent somebody else who does want this right to make that choice?
Is there a follow-up on that?
The previous question.
Okay,
Do you
go
mind?
ahead.
What if, in the case of someone becoming mentally incompetent but still able to swallow a pill? Still not.
Did you all hear that? If somebody becomes mentally incompetent but can still swallow pills?
Yeah. If it's in their directive, they still cannot. A family member, wow. Okay.
Can a healthcare proxy represent the patient in that instance?
A healthcare agent can make medical decisions for a person who has lost decision-making capacity with regard to life-sustaining treatments, including hydration and nutrition, as long as they know what the person's wishes are with regard to those things, if they've been appointed to be the healthcare agent. But they cannot make any other decisions with regard to, for example, aid in dying. They can't give the medicine to the person just because they're the healthcare agent. The person has to have decision-making capacity at the time that he or she asks for and receives the medications. Now, maybe a small number of people will lose capacity during the time frame after they receive the medicines, but that's going to be probably a very small number of people.
Another reminder to talk to your loved ones about what you wish.
Absolutely.
And we intend to have a program on that as well. Here's one. This will only take a minute or two. What is the position of the church on this issue?
Which church?
Yes, it depends.
But it's a very good question. I didn't mean to put down the question. I don't know where we start with this. Michael, maybe with you.
Well, when you say the church, I'm assuming, hopefully, maybe I'm way off, but the Catholic Church, the Roman Catholic Church. And the official position, of course, is that the Roman Catholic Church prohibits physician aid in dying. But what's interesting is that when we come to the traditional distinction between ordinary and extraordinary treatment, which I don't think is a defensible distinction myself, it was the Catholic Church that promoted that distinction. And the Catholic Church who took an active voice in supporting passive euthanasia. This goes way back to Pope Pius XI.
Yeah,
He's 11th or
12th.
Was it 12th?
Mystici corporis.
Yeah.
Yes.
Way back. So it's interesting. The Catholic Church had a quite liberal view
Yes.
on withholding life support, but they still are officially opposed to any forms of active euthanasia.
May I add something to it? Still on the Catholic Church issue, when the referendum passed in Washington, there was strong opposition by the Catholic Church, as we've seen also in Massachusetts 2 years ago, maybe 3. But at that point in time, the church was plagued by sex scandals, and the parish in Washington state that was trying to fund the opposition to the referendum in that state had lost a lot of the money because they had to hide the money in some sort of cemetery thing so they wouldn't lose the money to the plaintiffs. But at the end of the day, they didn't have the cash flow to fund the opposition in Washington state. And I believe that was key for the passage of the referendum in that year there, because it had been tried before.
I think it's also worth stating that although the hierarchy of the Catholic Church clearly opposes aid in dying, a majority of Catholics actually support
Right.
aid in dying. As a majority of, I think, virtually every religion, even though some religious affiliations are against aid in dying, the Unitarian Church being one that's the only one that I know of that's actually taken a position in support. Some are, I think, take a neutral position.
Right. The Unitarian Church has actually been at the forefront of the social movement surrounding aid in dying since the 1950s. And yeah, there are minutes. They were part of the very first social movement organization in this country. Their leaders, Potter and so on. But yeah, the Catholic Church, we'll see what the future cards.
Can Natalie?
Orthodox Church.
Pardon me? Orthodox Church. Does anybody know?
I don't know anything about that.
Do you know, ma'am?
I think that's pretty consistent with the Catholic Church. It has very strong prohibition of that. I think the Orthodox Church is also quite very strongly opposed to passive euthanasia as well.
If there are other question cards, we can bring them up this way. Natalie, could you grab some question cards over here? The question is, what is passive and active euthanasia?
Well, I'm sorry for bringing that up. It's a kind of long, drawn-out philosophical medical ethics distinction. Example of passive euthanasia would be if I were in a situation, I'm terminally ill, and I request that my ventilator be turned off, or that any further aggressive measures be withheld. That's passive, right? It's passive. In other words, it's allowing the condition to take over the patient. And the physician in that respect is acting passively, or the nurses passively, turning off the ventilator, withholding, etc. Medical feeding would be an example. Even though the Catholic Church is opposed to that, by the way, with withdrawing medical feeding. Active euthanasia is, suppose I request that instead of having my ventilator turned off, I want my physician to give me a lethal injection, an embolism. Well, that's quicker. But he's actively now bringing about my death or hastening my death. You see, and the Catholic Church has a strong position against that. But that's basically the distinction. I think morally, and David raised this point, is there a moral distinction between allowing someone to die and actively killing them? Very interesting question, philosophically. I'm not sure. I'm not sure that I could propose a strong defense for that distinction between allowing someone to die, letting someone die, versus killing them.
Of course, today, as opposed to 60, 70 years ago, people who are, quote, allowed to die have already been receiving unnatural treatments to keep them alive. So it's not a natural death in any event. Hardly anybody dies essentially, quote, naturally anymore. And I think I want to take issue with you, Mike, on the question of the Catholic Church's teaching on the issue of the withdrawal of medical nutrition and hydration. I think, as much as I disagree with the position of the Church on aid and dying, of course, I do think that they allow the withdrawal when a patient is actively dying, but not until such time as the patient is actively dying. So you do need to consider, if and when you're going to go into an institution, a hospital or a nursing home, what the policies are of that particular institution, because if it's the institution's policies to follow strict doctrine of the Church, then it may be a consideration for you as far as whether or not you want to go to that institution or some other institution.
I'd like to add something on the issue of active euthanasia. I don't want to create confusion, so it's a disclaimer right from the get-go. Yes, but the way aiding dying happens elsewhere, other than the U.S., particularly in the Netherlands, involves the actual administration of a lethal drug in the arms of a patient. And in that context, where this practice has been tolerated since the 1980s, the argument that has been raised by the profession of medicine, and in fact it's the only association in the world that affirmatively supports the involvement of physicians in aiding dying, the argument they make is things can go wrong when you have the self-administration of medicine by the patient. And the argument they make is that if you have a physician actually injecting you with the lethal medication, there is no room for errors in terms of throwing up the medication, as has happened here, if you read the reports in detail. But again, the context there is absolutely crucially different from here. To give you an example, 97% of people, of the Dutch people, trust their physicians. Yes, okay? They see their physicians on average 5 times a year. 2 of those visits are in their home. The physician, they're called huisarten, treat the whole family, not just you. So they know you, they know your family. It's a very different dynamic from here. So it makes sense there. What we have here in Oregon and the other states where it's regulated by statute is the self-administration working, in effect, as a safeguard checkpoint in the process, where you're really, really preserving the choice by the patient. And that works for this context here.
I'm sure Jesus didn't mean to dissuade anybody from ever taking the medicines, but it's only been a few people who have regurgitated the medicines and who've taken them. There are protocols, and they do work really, really well.
Yes, I know of 2 cases. 2 cases, and it's unclear from the reports whether the antiemetic that should have preceded the actual medication was in fact taken. So the way it works, the medicine that's most widely prescribed comes as, I think, about 100 pills that are, diluted and mixed often with applesauce. and ingested after the person takes an antiemetic to keep the lethal medication down. But these two cases did happen.
All right, so here's an interesting question that is kind of related to that one. Is it harmful to the organs to take one of these drugs if you want to be an organ donor?
Oh, I want to answer that. I want to answer that. Okay. I'm jumping at this opportunity because this has fascinated me all along. Because most of the people who use this law here and abroad tend to be people suffering from cancer. And donation of organs by cancer patients is mostly prescribed, right? You can understand the reasons. So what has happened in Belgium for the past 20 years is a shortage of organs for donation. And there have been some studies as to whether using organs donated by people who have used the law there makes more sense. So it's kind of created a market in a sense. And the practice has been criticized there quite vociferously for that reason. But again, it's a different context, and the doctors are on the side of it. Because the drugs that are used there, it's defended in that context, do not harm the organs, and there is a shortage. But it's, again, a very different culture and context.
This question is about the 6-month, the diagnosis of somebody having about 6 months to live with a terminal illness. This question writer says, what is the origin of the 6 months? I think the 6-month requirement is arbitrary. Any terminal person with an illness, I can't read the writing, should be able to avail themselves of this without waiting until they are so close to death. David?
6 months is the standard for eligibility for hospice care. It's a standard generally for diagnosing a terminal illness. It's a standard which is used under what's called our Palliative Care Information Act, which I just want to mention to you folks for a minute because this is a very important law which was enacted several years ago, which we actually initiated. It now requires in New York that the attending healthcare practitioner who is either a doctor or a nurse practitioner who has made a terminal diagnosis, meaning that their patient is with a reasonable degree of medical certainty is going to die within 6 months, has to offer to provide information and counseling to the dying patient on their palliative care and end-of-life options, including hospice. This law is unique to New York. A law, I think, somewhat similar was passed in Massachusetts not long ago. There's another law in California which is not as good as our law in New York, but it's something which you should all know about. But I think the 6-month standard, although you could say it's arbitrary, and so it is, it very much is in a way, but it's a standard that is used for determining terminal diagnosis, and it does give most people sufficient opportunity to make this choice as long as they have decision-making capacity.
There's currently a bill in Oregon to try to change that to 12 months. And there's a lot of opposition because it just taints the issue, creates confusion, and frankly, because of the hospice using the 6 months or fewer to live, it's just neat to keep these things with the same boundaries.
The 6-month determination is interesting because, and when we look, it's based on the outcome survival. And when you look at outcome survivals for different conditions, you're reading pretty much the statistics that are mean, the mean averages, yes. Or the median average even for that matter. But there's always the outlier. And we have to realize there's a distinction between the absolute statistic, the wider context, and the relative statistics. I remember my first hospice patient, Mary Wasilek. She was 6-month prognosis. Well, I celebrated 2 Christmases with her. And she kept, waiting for the next Christmas, and I'll tell you, so everyone's different. And that's I think that's a quandary that physicians face when patients ask them, how long do I have? They're put in a tough spot. I mean, how long do they have? It's hard to tell. And a lot of physicians can diagnose, but they have difficulty prognosing.
This is a relatively quick one, and then I'm going to ask Michael to try to read the 2 questions that were addressed to him that I can't read. Here's the quicker one. Did I understand that a person must swallow the medicine? What if the person is paralyzed or cannot swallow? David?
If the person can't swallow for whatever reason, they simply are unable to access aid in dying. And that's the long and the short of it. We have to draw lines somewhere and make distinctions. Most rights are not absolute rights, and so this is the line that's been drawn. I think it's a reasonable one. Again, when we think about trying to get laws enacted in this country to establish aid in dying, we have to be really careful about how fast we go and how far we want to go in defining what rights people have to aid in dying. And so I think this is a reasonable way, for now at least, of making a distinction between those who can swallow and those who can't. If you've missed the opportunity, and some people unfortunately do, although not many, it's very unfortunate. But I don't think that should be changed, or we should make any effort to change that again in the near future. And we should all be focusing just on what we possibly can get in this state and in this country in the near term, which is what we have now, which is the ability for someone to swallow, to be able to take the medicines in order to achieve a peaceful death.
I'm going to turn it over to Michael to see if you can read those questions. Then I'm going to have one more here, and then we'll wrap things up.
Professor Brannigan, you are full of it. You need to, I don't know why you were asked to be on this panel.
That didn't say that. That's not true.
It says, even without being able to provide a definitive answer, thank God, how do you think a changing sense of time might affect our sensibilities on this issue? What are some of the possibilities? Well, by changing sense of time, I assume that the questioner means our time consciousness, our view of time today and how it may unfold in the future. Well, that was pretty much the point that I was stressing, is that we have to somehow get out of our time zone and think about the long-range possibilities. In other words, short-term benefits, and we always deal with this. Short-term benefits, we have to balance that against long-term possibilities and risks, right? Short-term benefits, absolutely. I would want to be given the option to end my life. But should that be acknowledged and sanctioned and universalized, down the road, how would family members view their relationship with the patient and the individual's decision-making? That's all. I believe that how we view time is very important in terms of how we view our relationships. Just as technological devices regarding communication. Just think of how the quality of communication is so affected by smartphones and texting. It's changed the quality of communicating, what it means to communicate. So also our sense of time. Would David, Jesus, add any more to that?
No, go ahead. We need to kind of wrap.
Okay. The terminally ill know that he or she has a definite amount of time left. But you do not know whether we will reach home alive after this semester. That is no reason to give him or her a different right. I would rather improve the palliative care in the hospice for everyone. A great point. Well, that's one of the things. We can't predict the future. We cannot predict that. And David mentioned palliative care. perhaps when this is brought up for legislation, I think we need to rethink palliative care and make more of an urgent effort to strengthen that. The problem with palliative care is that that's not reinforced that much in hospitals. In medicine has its own culture. All right, the surgeons, saving life, rescue, rescue, rescue. That's stressed much more so than caring, than curing, in that sense of caring.
We clearly do need to improve palliative care. It's a growing, relatively new field. Things are improving. Most hospitals now have palliative care services. But regardless of the extent to which we can provide the best quality palliative care or hospice, not all suffering can be controlled. We know that. And because of that, that's why we have such a thing as palliative sedation. Not all symptoms can be controlled, whether it's pain or breathlessness or diarrhea. Not all existential suffering can be controlled. That is why aid in dying needs to be a law, regardless of what improvements we can possibly make, which are some in palliative care and hospice care, but we can never make sufficient improvements to reduce or to eliminate all suffering at the end of life.
May I offer some comfort from the world of evidence? In Oregon, it has been shown that the use of hospice services has actually increased after the passage of Death with Dignity. People are talking about it and learning about their options, and hospice is one of them. So one does not exclude the other.
That's right.
There's one question that is a very technical question about a particular form, and what I would ask, I think this is a good ending point. What I would ask is the person who asked about the Polst form, if you would...
It's Molst in New York.
Says Polst.
No.
I think there is a Polst
It's
as
Molst
well.
in New York.
Oh, in New York it's Molst. The person who asked that, if you would come up and ask David afterwards so we can get your question answered. But what I'd like to do is end on the note that we have here, and thank you so much for coming. And thank the panelists very, very much. You all did a wonderful job. Thank you. Thank you.